Let's get agreement that this is a strategic
Finding
priority.
that area of alignment and synergy can be very
Looking to
important.
the future, we're committed to expand
At the
value-based
same
care.
time, there's still progress that needs to be made.
This is Healthcare Strategies.
Hi, and welcome to Healthcare Strategies. I'm Olivia Kaler, Senior Editor of Life Science Intelligence and Pharma News Intelligence. Today, we are speaking with Dr. Chiruba Prabhakar about the recent U.S. Preventative Service Task Force breast cancer screening guidelines. Dr. Prabhakar is a minimally invasive surgeon and board-certified OBGYN. To start us off, please tell us a bit about yourself, and thank you for joining us today.
Yes, thank you so much, Olivia, and thank you for having me. As you mentioned, I am a board-certified OBGYN and a fellowship-trained surgeon, and I take care of women through all phases of life. And I founded and work in my own private practice in the Bay Area, where I provide gynecologic services.
Awesome. Well, it sounds like you are the right person to be talking to about this. So could you tell us a little bit more about the latest breast cancer screening guidelines?
Yes. So there are guidelines from different colleges and colleges of medicine and different task forces in the US. But the recent one that we're talking about here is the USPSTF recommendation on breast cancer screening. This recommendation states that women should start getting their screening for breast cancer at age 40, which is great news. And they want it done every 2 years, which is a little disappointing, but that's what we're discussing here.
Awesome. Great. So if you could dive into a little bit more of the impact that you think that these guidelines will have on cancer detection, and what impact do you expect the new breast cancer screening guidelines to have in general?
So breast cancer is a very common cancer in the United States. 1 out of every 8 women will be diagnosed with breast cancer, which if you think about it, it's really quite a common disease and condition. So out of 8 friends, 1 will be diagnosed with breast cancer. And so this is really important to screen and pick up as frequently as we can and in the earliest stages that we can. So we want to start screening at 40, which is great. That's where the USPSTF recommendations start. And ideally, we would want to do it every year so we can have the best chance of picking up breast cancer. Unlike some other cancers, breast cancers can be pretty aggressive. They can grow quickly. So from 1 year to the next, somebody who didn't have the disease last year could definitely have it this year. And I just worry that with this screening now being every 2 years, that we're going to be missing a lot of breast cancer. I am on the advisory council for AWHP, which is the Alliance for Women's Health and Prevention, led by Millicent Gorham. And we really fight for equity and access for all women. And now with these guidelines being every 2 years, we worry that not everyone is going to get screened. And we know that certain ethnic and racial groups are at higher risk for breast cancer. So Black women, for example, are at 40% increased risk. And so we really do worry that they're not going to be, getting the adequate screening. And lastly, in terms of impact for all women, we know that recommendations such as these influence what insurance companies will pay for or not pay for. And so if the guidelines state that it's every 2 years now, and yet I, as a doctor, feel like somebody really needs the screening every year based on family history or other risk factors, now that patient may be paying out of pocket, which is really unfair and unfortunate. So these guidelines are going to have ripple effects through all our communities and for women all through the country. Breast cancer is the most common gynecologic cancer in the US. And so I worry that, we're going to be missing a lot.
Yeah, that is a bit concerning. So now that the guidelines now suggest screening every 2 years instead of annually, do you know what the reasoning behind this change is? Is it if you're not doing it every year? It's obviously cost savings. Is that why? And again, how is this going to affect women's access to mammograms?
Yeah, so that's a good question. From the perspective of the task force, the USPSTF, they recommended starting mammograms at 50. So from their perspective, this is actually an improvement that they're now recommending 40. The American College of OBGYN that I'm part of has always recommended screening starting at 40 and screening every single year, which is great because as a practicing gynecologist, I pick up breast cancer more often than I would like to. And sometimes it's between years where somebody had a normal mammogram and then, they come in for their annual exam and I feel something. And sometimes it is breast cancer. And so from their perspective, from the task force's perspective, they're actually, doing a good thing by now bringing the age to 40. The part that's disappointing is the every other year. I believe their rationale is something along the lines of frequent false positives. So if somebody has an abnormal mammogram, then that leads to further testing, which then leads to a biopsy, which can cause, anxiety for patients and also, of course, healthcare costs. It's going to be more expensive to do all those tests. So I think this is why the recommendation is every other year. But I know that most women, if they have anything abnormal, they want to make sure that it is nothing, right? They're willing to go through the anxiety for those tests to, at the end of the day, have peace of mind that everything is normal. So to me, as a practicing GYN and for all of the women I serve, I think this is a little bit of a, slap on the wrist or a little bit of a blow that we're not being authorized to get it every year. And there's some people who are willing to pay for it, right? So some patients have the means to do that, but not everybody does. And with all of the insurance stipulations, these tests can become expensive. And so that's my concern.
Yeah, that makes sense. You mentioned health equity and access, but the guidelines don't specifically address women with dense breasts. So why is this an important population to consider?
Yes, so dense breasts, this is a big issue. Many women are being diagnosed with dense breasts now. I'm not sure that whether this is something that we're seeing more often now, or also our technology is becoming very, very good at becoming more sensitive to breast density. And so a lot of times women will get a report that says your mammogram is negative, but your breasts are dense, and this could obscure small malignancies or small tumors. And so when you read a letter like that, it's okay, great. So could I have breast cancer? And a lot of women are very anxious about it. In practice, I do send them for some further testing, often an ultrasound, or if they have a very strong family history, then we'll do an MRI. But yeah, this is another area where there is no recommendation. And I was really hoping to see something from the task force addressing this because this is a huge need. Many, many women have dense breasts and are just left not knowing what to do or just hoping for the best. Okay, I really hope they picked everything up because it says it's negative, but I'm still worried and concerned. So at the least, I was hoping that they recommend an ultrasound, which is what in reality, in an everyday practice, many doctors will recommend. But again, if it doesn't come from the task force, sometimes insurance doesn't cover it. And that's where it becomes a little tricky.
Sure. You need it from the top down for everybody to be able to do it, right?
Yes, exactly.
So, okay, that makes sense. Another aspect I can tell that you're very passionate about is health equity in underserved communities. I have a feeling you're going to be upset with these guidelines when it comes to those two things as well, just because it doesn't sound like it's going to be as accessible, especially for the underserved communities.
Yes.
Since it is every 2 years.
Yeah, it's every 2 years. And as it is, underserved communities sometimes have a hard time getting, your basic physical, your basic annual cervical cancer screening, all the basics. And so with breast cancer increasing at a rate of almost 2% every year, this is scary. It's really scary. And it's a point of high anxiety in the gynecologist's office. Everyone's always concerned about their breasts, and rightfully so. Another point that I also wanted to mention was the guidelines recommend screening from 40 through 74. But what about all the people after 74? People are living long. Women are, living well into their 80s now. We spend over a third of our lives in menopause, which is again above 50. And so it's almost like, okay, now we don't really care about you kind of thing. And we know that cancer in general increases with age. And so to me, it doesn't make any sense just to stop at 74. Really, that next decade is when the incidence of cancer increases even more. So we should definitely continue the screening until a patient doesn't want to or doesn't want to do anything about it. Once in a while, I'll have a patient who will say, well, even if my mammogram shows cancer, I'm not going to go through a chemotherapy and radiation and surgery. So there's no point in doing it, which is a fine decision. But other women will certainly want to do everything they can. And so that's also a little disappointing that they cut that off at 74.
Yeah, that's a really good point. I guess I didn't think about that. Yeah, like why 74? That's so obscure to me.
Yeah, exactly. We do stop for some other screenings at 77 for colon cancer screening because the risks at that point outweigh the benefits. So I understand that. But
Sure.
with a mammogram, the radiation is small. It can be a little uncomfortable, but it's not a very risky screening test. So it would have made sense to continue that till the patient wants.
Definitely. And so, could you speak a little bit about how the guidelines should be applied to the transgender community,
Yeah.
especially when transitioning?
Well, I think these guidelines are applicable to anybody with breasts. So
Okay.
regardless of where they are in that process, if they have enough breast tissue to get screening done, I would just still recommend that as a uniform standard for everybody.
Got it. Great. Thank you. And what factors need to be balanced when developing breast cancer screening guidelines?
I think some of the main factors to consider are the incidence of breast cancer. So, how frequently is it coming up in our population? Is it a growing problem, which it is? The rates of breast cancer are growing with time, and it is the most common GYN cancer in the United States. So, definitely those two factors. And then also the impact of the disease. So, the impact of breast cancer and the time taken away from work for these treatments, the mental anxiety, and again, time away from work, from family. I think all of those need to be taken into account. So, if we can provide screening that's a little more frequent and catch things a little more quickly, I think that goes a long way in terms of the downstream effects of then having cancer and having to incur more healthcare dollars with all the other extended treatment plans. So, those are some of the factors that I would take into consideration.
Sure. So, would it be safe to say, in your opinion, that a more robust guideline would be to, in the future, say every year, make it an annual exam? And then do you see anything happening in the future with the age? Do you see our system becoming more proactive and lowering that age limit?
Well, I sure hope our system becomes more proactive. I would love for it to be starting at 40 every single year with no cap on the upward age, because there are many women who are extremely active, very healthy, and will do whatever it takes to treat their breast cancer above 74. So we don't want to cut that off prematurely. And I would also like to see a standard recommendation for dense breasts. So if you have dense breasts, you automatically go get an MRI or you automatically get an ultrasound or some sort of standard so that it's not left up to the individual physician, the individual patient, how proactive they are, what kinds of services that they have at their fingertips, and if they can afford it or not. Those are just way too many factors that go into determining whether somebody gets appropriate follow-up, versus if it comes from the guidelines, then it's just more equitable. It's an automatic thing that happens, and we can be a little more certain that everyone is getting the adequate screening that they deserve.
Well, let's hope for more standardization.
Yes, definitely.
Let's go ahead and just round out the conversation. And I would love to ask you, what do you think healthcare providers and organizations should do to effectively communicate these updated guidelines?
I think definitely lobbying, at the state level is great, although that's harder to do on an individual basis for many physicians. But being vocal about it, especially on social media, is really great. And then just educating their patients as well about these new guidelines and in my office, I also give them the alternatives. Okay, here are the guidelines, but here's what I recommend, and still making the choice theirs rather than saying, well, this is what's approved and I guess we just have to, stay with it. But finding creative ways to still get it covered is important, and just keeping this conversation up so we don't go another 10 years before we make a change. So being vocal about it, such as this, coming on podcasts, so we can affect change for all of us.
Definitely. Well, thank you so much for coming on the podcast to talk about this. It's very important. So I'm glad that you're here today.
Yeah, thank you so much for having me.